Hey everybody, it's Matt here. I'm sitting down here with Dyan at the moment. It is late at night, unfortunately. It's actually 10:28 and it is Thursday the 15th of May. Dyan's not doing all that wonderfully well, so we're on wait and see. And she's just having a bit of dystonia in the face at the moment as well. This is the day that we've been at the hospital for about 5 hours. Same day, different time, and the pain that she's going through is quite intense now. A lot of this is now, apart from the exhaustion, the physical fatigue, is to deal with the gastroparesis. You want a bag? Alright, we are organised. I've got pulse oximetry on because I'm expecting, unfortunately, as I said a little bit earlier today, some of the things that she's been through are likely triggers to what she's about to experience. She's had all her night medications, everything has been done. Oxygen stats are currently at 95% and they're dropping, heart rate's at 55. John's been to the hospital to see an ophthalmologist today. Oxygen stats are just dropping down to 94. You may hear some alarms and alerts go off soon. She is tired, she should be sleeping, but she has been in incredible bowel pain because of the gastroparesis. So I'm just going to bring her down. Oxygen stats at 94, heart rate's at 56. Gotcha. So the trip out today has unfortunately put us back in being able to manage a few things. One of those was the furosemide, so that's the diuretic or loop diuretic, to try and get some of the water weight from the full body edema. So we've had to pause on that whilst we're out because Diane couldn't manage that whilst also being out. She's taken that late when she's got back in from hospital. At the same time, she's got gastroparesis, so she's had to pause taking medications while she's out of the hospital because you can't be going to the toilet every 10 or 15 minutes whilst you're in a hospital environment, unfortunately. But it's now causing her intense bowel pain, and that's what she's trying to deal with. So she's been a very brave girl having to go to this appointment today. Just getting a line nasal cannula ready just in case. Read. So temperature's not much. It's only 36.7, so she's actually quite reduced. She hasn't taken any additional medication. She's been very avoidant of taking any strong pain relief. She has been offered the gabapentin and the Panadol Osteo, but she hasn't taken any of those. Now I have just given her some Enos to help with the stomach. Turning up a little. I'm just going to take your blood pressure and then I'm going to take you up, okay? It's better for me to take it flat to get an accurate reading. Of course, with orthostatic intolerance, if we sit you up, it'll increase the blood pressure reading naturally. And that was part of the problem in going to the hospital clinic today for the ophthalmologist, 5 hours. She was having to sit up in a wheelchair the majority of the time. She got to a point where after doing 5 separate different tests, you do your pressure test and you do long distance reading tests and you do a scan of the eyeball, and then you've got a pupil dilator and then a colour thread that you put into the pupil as well. So after doing 4 or 5 tests, the ophthalmologist said, oh look, There's another test I want you to do, but you only need to take these drops. It'll take you 20 minutes before I come and see you again and say, well, you've got two choices. Either we reschedule and do this on another day, or we get her laying down because she is going to be seizing in the next 2 to 3 minutes. Don't have any choices on that one, dude. She's been sitting up in waiting rooms in a wheelchair, even though she's got a J collar on for her neck CCI. It ain't working. This is not the environment. Heavily overstimulated, having to do all these tests, engagement, answering questions. It's exhausting for a patient who's normally in bed. Blood pressure is 95/57, heart rate's 58. Now remember, Dyan's normally 80/65, just to give you a bit of an indication there. So a little bit more elevated with the pain. Room temperature is 25.7. It is 15 degrees outside at 10:34 p.m. So this pain's been going on for a while. Indications for the right hand to the chest that she might be getting some chest pain, which when you're taking bowel medications is another expectation as well. Dyan, you're getting chest pains? I'm going to give you some GTN. Heart rate is at 56. Nothing much sweetie. Nitrolingual spray, 10:34. Hey Google, set timer, 5 minutes.
Okay, 5 minutes. Starting now.
We're setting a 5-minute timer just to see the response to the vascular constriction change. And see if the nitrolingual spray actually helps Dyan's heart and it settles down. Otherwise, we'll apply a secondary spray after the 5-minute mark. Oxygen stats are at 96, heart rate's at 55. So yeah, the activity of going to a hospital today, clinic, cattle call, and it's obviously in a large waiting room with 30 plus other people. You don't get to control the time and the appointment scheduling or prioritisation. She's just having some blepharism and oromandibular dystonia at the moment in the face. There's a bit of palsy on the right side of the eyebrow, so it's drooping low. That's okay, we're getting nausea. Nausea is quite common, obviously, with the gastroparesis between GERD and reflux, vomiting. But it's also a preictal sign between seizures, so there's that as well. Air conditioner, just to bring the temperature down a little bit. You, my dear, I know, you're in a lot of pain. She's had some ondansetron, 4 milligrams. This is another medication that's commonly used for her gastroparesis for the nausea. She can have that 4 times a day, up to 8 milligrams per time. She uses a 4 milligram sublingual wafers, so she can have an increased load on that if needed. She's got a lot of allergies, so she can't use other medications like Stematol, for example. I'm trying so hard. Okay. Right here if you need anything. She's been going backwards and forwards to the toilet. Not that she's able to really walk unaided, so she needs carer assistance one-on-one to be able to get to the toilet and manage that and come back, but it's backwards and forwards. And that's exhausting. When you've had a day out at a hospital doing clinic appointments, it's actually very, very tiring, physically tiring, and then to have to then deal with the edema, the gastroparesis. She hasn't been eating properly today either, so she hasn't been able to get her regular amount of small quantity foods in because you're in a hospital environment. Like I said, you don't know how long it's going to be. You might only be there half an hour, you can be there for 6 hours. You just don't know. Managed to cost us $13.40 in car parking for street parking in Fremantle. We actually had to go to Fremantle Hospital because it's connected to its sister hospital, which is Fiona Stanley, part of the Southwest Metropolitan Hospital System, where they use the older hospitals for some of the lesser needed specialty appointments. We've been on a wait list to see ophthalmology. I think it's been like 16 months now since the third referral, because the first referrals were actually knocked back and pushed back for Dyan until they actually got the 22q11.2 deletion syndrome genetic result, where they then understood that yes, it's actually a requirement for any of those patients as a first line of management to check with the deterioration that comes with eyesight and hearing, many other organs, when you've got a condition that affects and deletes 3 million DNA building blocks. It's a micro, sub-micro deletion on the long arm of the 22nd chromosome, 30 to 50 genes. Turn it off. It's off. I'm going to take it off. It affects about 180 different clinical symptoms for Dyan, and she has a lot covering every different part of her body. That's why she's got about 22 different specialists that she has to see. Gastroenterology is one of those for the gastroparesis. She actually has an endoscopy and colonoscopy scheduled in just about a week and a half time as a procedure, which will be going into hospital because of this. So this is just a very mild case of taking a couple of medications to actually work through the bowels. Hey Google, stop. Hey Dyan, chest pain, how's it feeling? Okay, alright, good girl. Got the indication that the nitrile lingual spray has been sufficient. Current time is 10:40 PM. It is Thursday the 15th of May. So this is not the ideal situation of positioning, because obviously Dyan wants to sit up for the nausea to try and manage that, but at the same time she can syncope and pass out and fall over. She can atonic seizure and fall over and hurt herself. She can go into dystonia or tonic-clonic seizures in an upright position. And of course she can easily dislocate the sublux, various joints, knees and hips. So you have to be very observant during this phase. Oxygen starts as solid at 96, heart rate's at 69, elevated because she's sitting upright more. Whole thing. This is a regular thing. This is one of the frustrations why she doesn't want to go into hospital and do the procedures for the endoscopy and the colonoscopy, because she knows that she has to do a full bowel cleanse straight away. By doing that, she's going to be in a whole world of hurt with electrolyte imbalances, heart rate and respiratory issues and seizures and dystonia. Just so that the hair's out of the way, not causing any encumbrance. How do you go from should be falling asleep and tired to having to go backwards and forwards to the toilet with other medications that we should be applying, like suppositories and things to actually help with the bowel, but we just can't because she hasn't got the energy, and of course going into seizures and dystonia I can't afford to give those medications in case that she's then passing out with syncope or in midst of a dystonic or seizure, and then also then her bowels are flooding out. You can't win, so we've got to pace and time. Hop up, time. Syncope 10:42. Yes, sweetie. Come on. Come on. Come on, sweetie. Can we lie you down? No, of course not. It's alright. We'll just catch you each time, shall we? It's very difficult for Dyan, particularly being autistic, trying to manage these things between executive functioning, understanding what's going in with her body, with interoception, what the internal states are, feeling what she needs to actually do and manage. Yeah, the cognitive confusion that comes over with the seizures because it's the neurological side of things. None of that helps. And then you have blood pressure drops and respiratory drops, which then cause more things such as passing out. Oxygen pressure at 95 and steady, heart rate's at 75, expected to be elevated because she's sitting up. Normally her baseline heart rate should be around about 52 beats per minute. She is bradycardic, hypotensive. Come on. No. You're not falling over. Come on. Okay, well I can't have you falling over, sweet pea. Come on. Come on, Bubba. Come back here. Come on. And back up again. Like a yo-yo, isn't it? She's got pressure in the colon as well, so that's causing other parts of her organs to move around. Sweetie. Okay. Bubba girl. You're not doing too well, are we, princess? Hang back up again. Hold up, come on. She wants so desperately to sit up, to be sick, but at the same time she's got no muscle control to be able to hold herself up. Come on, my baby. Sadly, gastroparesis, dysmotility of the GI tract, all the way through, from top to toe. The GERD, the reflux, the throwing up, the compaction, impaction. Oh, look at your face. So we've got a blepharism in the right eye, that's why the eyelid is totally closed and not able to immolate. Just before this I was giving some enos to Dyan, so that's actually helping her stomach, hopefully in the gaseous bubbles. Being on her side is actually the best position with the knees up. It's the safest for her, she can't fall if she's lying down. Knees up to take the pressure off the stomach. Oxygen stats are good at 96, heart rate's dropped off at 54 though, but then she's also lying straight down. And sit down. She's taken all her night medications because obviously we have a very strict night routine. It normally starts from about 4:30 onwards. First medications come in at 5:15. Sleep hygiene is really important, particularly because of the ADHD. A lot of sleep issues in patients with 22q, it's very well known. And she hasn't actually been eating much, so she's actually quite dry in that sort of sense. We've actually cut back considerably on the food input while we've been out. We've taken a couple of the apple and raspberry, juicy fruit things for her to be able to get some nutrients and some energy whilst we're out. And your other leg, come back out here. Not good. What's it hurting, Papa?
My stomach.
Okay.
My stomach. It wants to go up. My dinner wants to go up.
Okay.
Pain.
The pain sucks. I've just been going through the pain management clinic at the hospital trying to deal with pain, and that's not an easy thing. We've done an initial orientation, and then I've had to go through 2 days intensive courses as part of our STEPS program, whilst we're waiting to now in the next 2 months get to see a pain fellow. That's the next stage of the process. Trying to find different medications that may or may not help, and they have to be tested very, very carefully. There's a lot of allergies, which result in anaphylaxis, just like the nurse today at the hospital asking about how many allergies does she have, and it's like onto the second page, and it's like, yeah, you do have a lot. Absolutely, and they should actually be on your medical file. Why are we having to give them to you? That's the part that I actually question, because the hospitals are all meant to be interconnected, and they should have the full patient profile. We shouldn't have to be sitting there giving out her condition, her medications, her allergies. Okay, let's take you to the toilet. Hold on for 2 seconds, Papa. A lot of pain just getting to the toilet. She wasn't able to walk without full assistance, and she can only shuffle her gait. Her feet can't even lift off the ground. And she'll probably have to go back a few more times tonight. It's currently 10:55 p.m. Our vlog channel is to give an insight into living with rare genetic conditions. Apart from the umbrella term, which explains where Dyan's conditions come from, 22q11.2 deletion syndrome, She's got a range of other conditions simultaneously going on. Ehlers-Danlos, hypermobility, that comes also under the banner of 22q. Dystonia is another rare condition. Having a fatiguing condition. Fatigue is quite common in genetic conditions and disorders. But Dyan's got a sub-branch of that, which is MECFS, myalgic encephalitis, chronic fatigue syndrome. I know you feel sick, kiddo. Try and bring your knees up. Just try and take the pressure off the stomach. Okay, the abdominals. Poor thing. She's so tired. Yeah, no. Can I give you some CBD because they'll give you some extra anti-nausea. Okay, and it'll help your pain as well. Your stomach needs to go, sweetie.
It's not breaking down.
Oxygen stats are at 96, heart rate's at 66.5 mils, CBD 1010, THC, CBD combo. Just leave it in your mouth, people. Whilst at the clinic today, Dyan was very Tourette'sy waiting in the waiting room, and that was coming out particularly in her vocalised tics and particularly coprolalia as well. It's a stress situation, it's not easy neurologically. She's already under stress just having to get out of bed, transport, and attend the clinic. Some of the tests, particularly like the light shining into the iris, taking photographs of the back of the eye. So the light was actually a flashing light. We already know that flashing lights photosensitively stimulate seizures in Dyan, so high risk activity, which we've got to manage through. And then you've got the ophthalmologist also doing testing with the eyes, eye tracking, rapidly changing, seeing how the eyes respond to changes in light, changes in a focal point. We already know through the tracking that connects to the muscles around the eyes, the blepharism. So that was triggering some mild blepharism, but also some oromandibular dystonia whilst he's actually testing her in clinic today. So it's okay. It's a good position. The medication I've given you will just kick in very shortly, okay? Just do whatever you need to do to be comfortable, alright? It's the important thing. I know it's a huge amount of discomfort, but a lot of pain. And this is one of the reasons why we're having to do the colonoscopy and endoscopy to see where things are at, why it's deteriorating, why it's getting worse, the impaction is getting worse, why things are not flowing with all the heavy industrial strength medications that we're using. So that's only a couple of weeks away. So the outcome of going to the ophthalmologist, part of the EDS, Ehlers-Danlos, is the consistent dry eyes, the inability for the coatings to be formed, the tear ducts are not performing correctly, so it's a consistent dry eye sensation. Dyan needs to use eye drops and a liquid tear replacement consistently, multiple times throughout the day, every day. So it's something which is not going away. It's quite known for patients with Ehlers-Danlos. So if you're one of those people with that condition, be mindful that may be related to why you have your own dry neutral eyes. The eyesight prescriptions have flipped and have become different and are non-effective for Dyan. We already know that she's tripping and falling, having problems with convergence, with tracking, just judging depth perception, neurological. And that was really the exercise of why we're going. We needed to differentiate, is there any structural issues? Because 22q being midline can cause structural issues and deterioration of the eye. Going through all the tests, no, there's no structural issues. Yay. what it all relates to, as the ophthalmologist is saying, is referrals back into neurology, because most of these things, like we already know, are the full body dystonia. Blepharospasm is just one part of it in the eye. The balancing ataxia, the accentuations of the dyslexia, issues with the aphasia, all of these things are neurological. We need help from the neurological team at the hospital to do their part. But isn't it stupid how you have to go through these other steps to go, yeah, structures are fine. You guys that are there in neurology need to be doing things, helping, medications, treatment, supports. Anyway. Very beautiful. Anything I can get you? Yeah, that's the problem, because some of the medications I need to give you to evacuate will make you more nausea and just so tired, and most likely definitely trigger more of a seizure. So we've got to go slow and gently, and that exacerbates and drags it out. I know you don't have the energy. Get up. I know, kid. I really do know. I'm so sorry. And of course, if I give you medications for pain, they will probably likely cause more constipation. Go figure.
Certainly
can. Absolutely. Right, hot packers on.
No, that's the right way.
You got the right way? Okay. Good girl. Wrap it around your tummy.
It was painful.
It is painful, isn't it?
Yes.
Can I do anything to help you at all? I know you're scared of being sick. If you need to be sick, it's okay.
I know.
It's okay.
I know.
Sometimes it's better to go than not.
I'm going with what my body says.
Yeah, exactly. Follow your body, listen to your body.
No.
Well, your body needs to make some decisions.
Yes.
We're getting some twitches, some tics, some generalized dystonia. This is the conundrum, and I want to point this out really. This is where our great difficulty is. To give the medications or suppositories, other bowel medications, which I know I need to do to help flush things out, are going to cause far more noise. It's going to create an imbalance in the electrolytes. It's going to cause more stress on the body symptoms, which is without fail likely to then cause seizures and more dystonia. They'll in part then cause, if I'm giving strong medications for the bowel, definitely going to cause more stress on the heart. We've already had some GTN spray tonight, and heart rate's been flapping around. Oxygen's actually flapping down a little bit at the moment, at around about 93%. Heart rate's at 59. We do have thresholds and threshold alarms. If I have a threshold alarm for the oxygen, then I'll put a supplementary oxygen on for Dyan. We took that with us to the hospital, as we do now on any trip out, because Dyan's oxygen saturation levels are dropping quite considerably throughout the day for no reason, okay, without tied into a seizure or a dystonia or anything along those sort of lines. Just the way her body's deteriorating. It's okay, just rest as much as you can. Sleep is going to be your best thing to help ease off any pain. Alright here. You're doing so well, darling. I know you're in a lot of pain. Problem with some of the other pain relief medications, they may not also be absorbed because of the amount of infection, constipation that are going on. So some of the things aren't going to be as efficient or as effective, or they'll certainly cause more nausea, covering the level of pain that Dyan's in. Can't win. This is the catch-22, and funny I say that, catch-22 ties into the syndrome, 22q 11.2 deletion syndrome. One of its names that was known by was catch-22. It's had lots of different names in the past: DeGeorge syndrome, Spritzgen's, Spurgeon's, phylocardiofacial syndrome. Over the years, and obviously with the advances in medicine, and particularly genetic medicine, they've realised that all these separate conditions were all tied under the one genetic block or genetic code, a deletion or duplication in that 22nd chromosome, and that related to all the symptoms, and that's where they then combined all of those sub conditions, as they used to be known or discovered in the olden days. They now reuse that name 22q as the proper clinical definition for that whole group. We don't use the separate names anymore, because we need to be understanding that if you've got that deletion, you might have a whole range, 185 plus different types of clinical symptoms going on at the same time for you. So it's important to keep up with the advances in medicine, genetic science and research. That being said, we're under multiple researches. For example, the bilateral calcification in the basal ganglia in Dyan's head, that which affects the signaling, which causes dystonia and the blepharism, the activity that Dyan's seeing. We're under what's known as a FARS disease. FARS disease is when you have bilateral calcification and a movement disorder, which Dyan has. So she's under Professor Henry Holden in the UK for research in that condition. We're under Murdoch University here in Perth, looking at rare and genetic conditions. We've reached out to UWA, University of Western Australia, to look at their rare conditions around dystonia and ataxia in genetic research. So we're doing a lot of things where we can to keep to the cutting edge to try and find out the science as it's evolving in the space, options for Dyan now and in the future, whether it's things like patch clamp technology that looks at replacing the genetic code that's missing to help the interpretation, modifying current medications using in an off-label sense to help with different conditions or symptoms that Dyan has. Oxygen stats are stable at 95%, heart rate's at 53%. Okay, I know it's dark, bear with me. It's 11:06 p.m. If I can get Dyan to a point where she's comfortable through sleep, so that the pain's not there, then that's what we're going with. And I'm going to have to monitor obviously symptoms, and if she needs to move to the toilet, I'll be up moving her backwards and forwards. And of course, as we go through this, I'll be having to monitor heart rate and oxygen drops. All the alerts and the alarms are going to be staying on. We're just going to try and keep her rested so that the pain is not working at her, and hopefully it will ease off progressively. Guys, thank you so very much for being around as usual. Hopefully this gives you an insight. That's the whole idea why we do the channel, to educate and advocate around genetic conditions, particularly 22q11.2 deletion syndrome, to inform you what patients' experiences are like. There's no real longitudinal studies for patients. They just don't have the research. They haven't got the years behind that. A lot of the data is outdated, particularly under separate conditions. Like I was talking about Webster George or Spitzens, not everything collaborated under 22q. Some of the data doesn't include the variables of those that have been lost, particularly those in pregnancy or in the first year or so of life. So we have a lot of people, a lot of things that need to change progressively, and that's what the research needs to be focusing on to hopefully bring this information together. Big thumbs up of encouragement to her. Thank you so very much for being here through this episode as usual. If you have any comments, questions, ideas and suggestions, leave them below. If you're new to the channel, don't forget to subscribe and hit that notification bell so you know when more episodes come up. And thank you for watching. Bye for now.